Okay, thank you for joining us for our live webinar where we'll be talking about Frontline of mental health as part of Mental Health Week. So my name is Professor Tom Byrne. I'm a professorial research fellow at the Queensland Brain Institute and also work for the Queensland Centre for Mental Health Research. And my lab is interested in looking at neurodevelopmental disorders such as schizophrenia or autism and trying to find biological underpinnings for why people might get those disorders and hopefully to look for better treatments into the future. So let's start with acknowledgement of country. So I'd like to acknowledge the traditional owners and their custodianship of the lands in which we meet today, with the Yagara and Turrbal people, pay respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. For those of you who aren't familiar with the Queensland Brain Institute, we're in our 20th year and we have over 350 staff who are looking to unravel the mysteries of the brain, trying to work out how we generate new knowledge, understand learning and memory, develop new technologies, and improve lives. And of course, diagnose and treat brain diseases, including mental health disorders. So before we get started, we have a few housekeeping items. So on the Zoom, there'll be a chat feature. So if you wish to pop any questions at all in the chat, then we can get to those after our speakers have given their presentations. So today's discussion will speak really about three aspects of the front line of mental health. Firstly, what's the problem? Second, what's being done to manage it? And third, what might be done to help prevent it? So I just want to contextualise this as a physical health problem. So let's imagine somebody slips and falls and then they have a symptom which is a pain in their arm. They present to an emergency department and then maybe they go in and they get an X-ray. Depending on the severity of the injury, they might get a cast and they'll have a plan for how long the cast needs to remain on, what needs to happen afterwards, some physiotherapy and about recovery. They may even go back to the site and look to prevent someone falling in that site in the future. But let's say what happens if you had some persistent sad thoughts, or maybe you had a thought of hurting yourself. What would you do? So those three questions we're going to talk about today with our panel. So this webinar is being recorded, so if you have any difficulty with the live session, you can always go back and look at the pre-recorded broadcast. So to introduce our four speakers, on my right we have Professor Ed Heffernan, who is the Director of the Queensland Forensic Mental Health Service and a Professor with the Faculty of Medicine at the University of Queensland. Directly next to me is Dr. Megan Purvey, who is an early career emergency physician, currently working at the Royal Brisbane and Women's Hospital and the Queen Elizabeth II Jubilee Hospital Emergency Department. To my left is Dr. Zoe Rutherford, who heads the Mental Health Evaluation Research stream at the Queensland Centre for Mental Health Research and is also a Senior Research Fellow with the University of Queensland School of Public Health. And on my far left is Dr. James Kesby, who's a behavioural neuroscientist, also at the Queensland Centre for Mental Health Research, Queensland Brain Institute, and he's a lecturer in the Faculty of Medicine at the University of Queensland. So to begin with, we're going to start with Professor Ed Heffernan, who's going to talk to us about certain aspects of forensic mental health. Over to you, Ed.
Yeah, thanks, Tom, and thanks very much for inviting me along today. I thought it was really interesting that this morning there was an article in the ABC titled "Mental Health Patients Waiting Days in the Emergency Departments Due to Chronic Bed Shortage." And I think that's a really important point because, you know, currently what we know is that the mental health system is under strain, and across Australia there have been increasing presentations to all emergency departments with mental health problems. And we know that the AIHW reported that in Queensland over the past 15 years, the number of mental health related presentations to emergency departments has actually more than doubled. So it's really a significant challenge at the moment. So it's very topical that we speak about this today, I think. In the area that I work in, which is forensic mental health, what we've seen over the last 5 years particularly is an increased number of people with mental health problems coming into the criminal justice system, so into the courts, into the watch houses and into the prisons. And this has been a real challenge for us to try and meet the mental health demands. Because the other area that it's causing a big challenge is for our first responders. And, you know, I know, for example, for the police that they have, you know, an increasing demand to respond to mental health crisis. I thought probably a good place to start today would be to talk about, well, what actually is a mental health problem? And the way I think about it is that we have a mental health spectrum. At one end is really good mental health and at another end is poor mental health. And things impact on that spectrum. So, for example, a person might have mental illness, they might have an untreated mental illness, and they might have poor mental health as a result. A person might have mental illness and they might have treated mental illness and a very happy life, and they might have very good mental health. A person might have a psychosocial problem, a relationship breakup, grief, loss. They might be in a domestic family violence situation. They might have experienced trauma of some description, and they might have really poor mental health. So there are a variety of things, and I think the key message is that mental health problems are a really heterogeneous set of problems. The next thing I thought was important is what actually is the mental health system? Well, the mental health system includes, I'm probably not going to include everything here, but includes private and public mental health services, which have both inpatient and communities. There are NGO services across the mental health sector. There are peer-led services. There's a large primary network, including general practitioners, and of course, police and ambulance are often responding to mental health problems. And in fact, one of the innovations that we did in the mental health system was to set up a service inside police and ambulance call centres, because we heard the police and ambulance were getting a lot of mental health related calls in their call centres. We didn't know how many, so we thought we'd try and pilot a service. So we set up a thing clumsily titled called the Police Communications Mental Health Liaison Service. We also set up a mental health liaison service for ambulance, which they now run. And when we did that, one of the things that I noted, being the psychiatrist involved in that service and reviewing the cases that our clinicians were involved in, was that there just seemed to be an extreme number of mental health crisis calls, and particularly suicide-related calls. And this is a real concern to us. Our clinicians, they provide information to police to help police respond in appropriate ways to people that are in mental health crisis, and they also help grease the wheels of the mental health system. And so the service helps respond to mental health crisis in ways that ideally produces better outcomes for individuals. But we did notice that the service was really inundated and that the call centres were really inundated. So we did a piece of research which was called Partners in Prevention. Now, this was a true partnership, but I'm not going to go through all the organisations, but there's a slide that'll show them all. But a couple of things just to say about this piece of research. It was funded by the Suicide Prevention Task Force. It was actually, as I said, a true collaboration between multiple organisations. And we had lots of brilliant people working in it. And I particularly want to acknowledge Dr. Carla Merck, who did some fantastic work in this piece of research. We did a number of pieces of research within this bigger project. So one was looking at the knowledge, skills, attitudes and confidence of police responding to mental health crisis. Another was to talk to people who had a lived experience of mental health crisis and to see how they feel things would benefit them in a mental health crisis response. We mapped the services and we did a very big data linkage study, and I want to just touch briefly on that. So the data linkage study involved 70,000 individuals who were the subject of 220,000 suicide-related calls to emergency services, and that was linked to 20 million health records. And in those records included the mental health database, drug and alcohol database, hospital admissions, emergency department, perinatal, the National Death Index, MBS and PBS. So a very rich source of data. So how does this actually help us? Well, there's some really interesting findings came out of it. So the first thing is that we found that there were, on average, 210 suicide-related calls to emergency services every day in Queensland. So that was the first thing. And that's actually quite a significant thing because nobody had counted those numbers before. And it gives you a sense of demand and why there might be pressures in the mental health system. The second thing was that we looked at some of the demographics, which are very interesting. So females were actually slightly overrepresented. Aboriginal and Torres Strait Islander people represented 13% of the sample, so very overrepresented. 11% of people were under 18 years and 6% were actually in the perinatal period. So this in itself is really important for service planning. Also, we looked at the age structure. So what was the peak demand? Well, interestingly, and I think quite sadly, it was females in the 15 to 19-year-old age group. And in fact, females in that age group had a demand that was 2 to 1 compared to the males. So really double the demand. Another thing that was important, and that I'm sure Megan will be interested in, is that 70% of those individuals actually had an emergency department presentation on the day they had contact with the first responder. But only 21% actually had a confirmed diagnosis of mental illness in the state's mental health database. So that's actually quite relevant. So what does that mean? Well, that means that there are potentially really significant psychosocial challenges that people are facing that they're actually presenting to emergency departments for. Things like relationship problems, homelessness, financial problems, trauma, domestic family violence, intoxication. So I think this raises some really important questions, Tom, that we might unpack further on this panel.
Yeah, that's really interesting, Ed. I mean, those statistics are pretty alarming. I sort of had a question about, do you think this is a way that we should be managing mental health services, where people in crisis are calling a phone line or presenting in emergency departments? Do you think that's a failure of other systems, or do you think we need to build capacity of these phone services and emergency departments to deal with this burden of mental health in the community?
Yeah, well, actually, that's a really good question, and I think we need actually a selection of doorways into the mental health system. So, people do tend to call, and they do tend to call emergency services, and of course then they're asked police or ambulance, and and I think that kind of makes it difficult for people. I think one of the big innovations and one of the things that we can do in the mental health system is to try and be there in real time to assist first responders. How do you do that? Like, you can't actually physically be there. Yep. Although there are co-responder models, but you can't physically be there across the state to this number of calls. But how do you do that? Well, technology, has really helped us do that. So I think in answer, we're always going to get calls. Technology will help some of that, but yes, there probably are better pathways for people, and certainly the primary care network and some of the NGO services and peer-led services are really important ways to access mental health care and treatment.
Thanks, Ed. And just one other quick question. I mean, do you think it would help if we improved mental health literacy generally in the community so that there's a better awareness of when people are in crisis to help support networks?
Yeah, look, I think that's really important. I mean, today we're doing a big campaign on breaking stigma in mental health, and I do think that awareness, understanding what mental health is and what mental health symptoms are is really important. I think there's still a stigma around mental health, but I think equally important is knowing how to access the right mental health care. Mm-hmm. And I think that's probably an area for some ongoing future work.
Yeah, fantastic. Thanks, Ed. I think we might move on. And so you've brought up emergency departments. So I think we're now going to move to Zoe Rutherford, who's going to talk about her experience. Megan Purby, sorry.
No problem at all.
Megan.
Thank you so much for having me today. And we'll get to Zoe soon. I'm going to talk about my role as an emergency physician, and obviously I've spent a lot of time in emergency departments throughout my training, and I'd love to say that this is all a new problem, but unfortunately it's been a problem for many, many years, ever since I've been working there, but it's definitely getting worse. In summary, the emergency department, it's a busy place. It's getting busier. We're seeing over 2% increase on presentations every year. And it's not just the numbers, but the acuity is increasing. Our patients are getting sicker, and this applies to the mental health patients as well. Things are becoming more and more complex. And we're seeing a high number of representations for patients than we previously did in the past. At the Royal Brisbane Hospital, we're quite lucky to be co-located to a psychiatric emergency centre, and we refer about over 3,000 patients a year there. That's just the numbers for who actually goes through the doors. We have a huge number of other patients where mental health clinicians come out and review them in the department, and then others that we review and may discharge home ourselves with follow-up plans. Everyone talks about long waits in EDs. It's obviously very topical, but the group that is most likely to wait longer than 24 hours is our mental health patients. I think everyone knows these are pretty concerning statistics. I just want to talk a little bit more in detail about what it looks like to work in an emergency department, particularly our typical sort of evening shift at the Royal Brisbane Hospital, and what this might be like for a mental health patient being there. So, as I mentioned, we're a tertiary ED. We're lucky enough to have our be supported by PEC, as we call it. When you work in the area in ED of acute, where we see most of our acute mental health patients, this is comprised of 16 bed spaces and 4 chairs. At about 6 o'clock in the day, we lose half of our medical staff. They go home. We don't lose them. They go home for the day. And then we're left with about 4 doctors and 6 nurses to look after these spaces. It's a pretty fixed space on who we can examine in there at the time, and we overflow into the waiting room from there. By 6 o'clock in the afternoon, there's already about a 2-hour wait for all patients to be seen, and we're starting to see patients ramping with the ambulance by then. The PEC has usually reached capacity, so the overflow from PEC is the emergency department. So it's pretty normal to have our chairs, our four tiny number of chairs already filled up by patients suffering with psychosis, suffering with suicidal thoughts, suffering with mania. Many of them have been brought to hospital unwillingly by police or ambulance under emergency examination authorities, but appropriately, the majority of them, there's very few that we end up saying, no, this wasn't appropriate for this patient to be brought here. We're quite concerned when we see them as well. According to our Australasian triage scale, these acute mental health patients should be seen within about 10 minutes of arrival. So we have a department that's full. We're getting 2 to 3 of these mental health patients every hour, as well as about 10 to 20 other patients with other physical complaints. And with staffing, it doesn't add up. We fall behind. By 8 o'clock, the department's absolutely heaving, and it's all downhill from there for the rest of the shift, handing over to the night team. Those that can't be seen in the department are then overflowed into the waiting room, which we treat and manage, and we sometimes have to start seeing them out there as well, which is far from optimal. So what treatment do we provide in the emergency department for people with mental illness? Our main role is to provide symptomatic treatment, mainly for those with thought disturbance or anxiety or a particularly elevated mood. They're the ones where we have medications that are quite effective in the short term. We provide a risk assessment and medical clearance, but then we refer them for mental health review, those that require it. We're really not initiating much meaningful treatment. It really is a risk assessment that we provide as emergency clinicians. These mental health patients are a really complex group, many often suffering also from drug addiction, from poor social supports. This is part of the reason why we can only really discharge a small proportion of it. It's hard to find safe discharge planning for these types of patients, particularly after hours. People might think of the emergency department as a place of safety. A lot of people bring their loved ones to us when they're concerned about them, and I know it's quite frustrating. I know they're quite disappointed on what services we can actually offer. It seems that you need to be really unwell for us to be able to help you. Sometimes it must be quite frustrating. And the other thing is, sometimes the reality is that unless you're at imminent harm to yourself or someone in the community, then the ED environment, it can make things worse. It's not a therapeutic place. As I've mentioned, mental health patients often have prolonged waiting times. As the evening turns into night, the chairs that these patients are sitting in become their beds for the night. It's unfortunate, but with our limited number of beds, often they're reserved for elderly patients or patients requiring resuscitation, and even those are being turned over pretty quickly once you're not requiring them anymore. We have patients start to wander around the department. We're constantly asking people to return to their chairs. These are people often with perceptual disturbances that we're asking to sit still in a chair for hours upon hours at a time. I don't know about you, but I'm not capable of doing that. Some days, yet we expect a lot from these patients that are suffering. And not only that, it's a really stimulating environment. The lights are on all day long. It's a really loud sort of background noise, and we've got alarms constantly going on. Many of our patients that present, they haven't slept in a few days, either due to mental illness or due to drug use. So the combination of the wait times and the environment does result in we get a lot of patients with escalating behaviours where we need security presence, and patients end up needing to be restrained and sedated to ensure the safety of staff and other patients in the department. And certainly without these environmental factors, this could have been avoided at times, but it's what things come down to. So I guess in summary, I feel that the emergency department definitely does have a role to play for managing patients in acute mental health crisis where there is imminent risk. But for those perhaps where there's less imminent risk, I think there's certainly better options. I hope Zoe will discuss some of our things that we're considering, and it was interesting to hear, Ed, what's happening in the pre-hospital space, and I'd like to know in future how we can link all of that together a bit better. Thanks
Megan. Sorry for calling you Zoe.
No problem.
Right. So I think that's pretty confronting what you're talking about. I'd be really interested to know, when someone presents to emergency, do you have any background information about the person, or do you have to extract all the information in a review there and then?
Yeah, so we do rely on some of our patient information services like the viewer to get a bit of history. Normally we would get a bit of history before we go in because, well, one, there's sometimes a safety concern, so we do need to have a look before we go in just to see if it's appropriate to send a junior doctor to see them on their own. But there is a disconnect between, there's CIMA that has excellent records of all the mental health patients, but we operate on a different system in the emergency department. Yes, we can get access to them, but it requires us sort of annoying the mental health clinicians every time. So we have some information, but we don't have all the information. We don't know if they've been seen in the community in the last couple of days. We don't know, if there was a plan for immediate follow-up tomorrow. There's a bit of a link missing there without us liaising with our mental health clinicians. Yeah.
And in terms of people not seeing you again, how are they discharged safely, or what happens if they're not discharged?
So if people aren't discharged, then they would get admitted. They would go into the psychiatric emergency centre, and then they would be assessed by mental health clinician, either a nurse or oversight by a registrar or consultant, who would decide whether that person needs to be admitted or not. Those that go home, like I said, you really need someone that's high risk. You need to have a family member or someone reliable to discharge these people into their care. And unfortunately, a lot of these mental health patients come in alone a lot of the time, and it makes it very challenging to find.
Do you find the same people coming back to the emergency department frequently?
Yeah, we have a large number of frequent attenders at the Royal Brisbane Hospital who we see some of them multiple times a week. And it can be challenging not to become too despondent. They're high-risk patients. They've got high levels of mental illness they're representing. It's challenging to know, to differentiate between these presentations as to when admission would be helpful and is required. Because, as we know, admission is not helpful for some of these patients either. So.
Great. Okay, thanks, Megan. We want to move on now to Dr. Zoe Rutherford. So,
thanks, Tom. So Ed and Megan have presented a really complicated kind of backstory as to the people who are presenting at emergency or are suffering from crisis. And it's really important to understand that there is such a really broad spectrum of people requiring very different levels of care. And particularly in ED, there aren't that many mental health clinicians available who have the skills to be able to support those people. So as Tom mentioned, I lead the evaluation stream at Queensland Centre for Mental Health Research, and part of what we do is evaluate community and health-based services for people with mental ill health, and in particular at the minute a lot of the work that we're doing is for Queensland Health, from children and youth through to adults and to older adults, and we're going to be working with some Indigenous projects as well going forward. It's really important also then to say, you know, it's not just about the mental health presentation as well, it's also about the groups of people who present, and, you know, the increased risk of mental ill health that, you know, Indigenous people face, people from the LGBTQI plus community, you know, young people, as Ed mentioned, you know, young girls in particular. And again, those add an extra layer of complexity that we're hearing and seeing from, you know, the data and also from EDs, but also then in the communities and these other mental health service providers like NGOs and so on that, you know, talk about, you know, it's not just the increase in mental health presentations that we're seeing, but also how complicated they are as well. So that then results in, you know, I got this from you, Megan, that actually it's really stressful in the ED, and you know, experiencing that day in, day out, it must be really tough. And we are hearing from staff that, you know, there is a limited number of staff, and burnout is a real problem. You know, you imagine hearing and seeing all these really traumatic experiences day in, day out really impacts on, you know, your capacity to be able to deal with that. So, yeah, it's pretty tough. What is great is that there are innovative pilots that are being introduced, particularly Queensland Health at the moment. So one of the evaluations I'm conducting is an evaluation of the crisis support space pilot across the state. So currently there are 8 existing crisis support spaces that have been rolled out in Westmoreton, so Ipswich Hospital, at the Prince Charles and the Princess Alexandra here in Brisbane. There is a more community-based one at the Gold Coast. We have one at Wide Bay, up in Cairns, and one in Townsville, and also in Mackay. So I think that's 8. And so as part of the crisis reform, Queensland Health committed money to the team to be able to fund these projects. And as you can imagine, the need of the different communities in those places are quite different. And so part of the evaluation that we're doing is to better understand how the generic crisis support space model, which is based on some established services in the UK called Safe Haven Cafes. And these crisis support spaces they aim to reduce all of the negativity, I guess, associated with emergency departments around them being overstimulating and potentially triggering, stigmatising, and so on, providing a really warm environment space for people to come to and to help manage their crisis. So these spaces look like your living room. You know, they do have coffee, not necessarily a cafe per se, but they're led by peers. So people who have experience of mental ill health and of crisis themselves. And we know within the literature and lots of advocate organisations how important the lived experience and peer workforce are in helping to support people with mental ill health and mental ill health crisis. So these spaces are usually, well, particularly 7 of them are situated next to the ED, relatively close. And whilst they're led by peers, they are overseen by clinicians. So you get, I guess, the best of both worlds, where you get that psychosocial support, kindness, and helping kind of the de-escalation of that crisis in the first instance. Get practical support around how to manage your initial crisis, but then plans going forward. And then opening up doors and signposting to opportunities within the community then to help managing the crisis thereafter. All overseen by the clinician, with the opportunity for the clinician to step in and then be a gatekeeper back into the hospital. It sounds counterintuitive, but a lot of these services initially you require a referral through ED for. all through the ACT team, so the acute care team, and some of them now are developing processes so people can self-refer. So in the same way that you see a lot of representation in the ED, and data tells us it's around 20% of all presentations, we're seeing that as well within the crisis support spaces. But arguably that's a good thing because they're not presenting to ED. So the aim, I guess, from a Queensland Health perspective, as well as making sure that people are getting the right care in the right context at the right time, is also about helping to divert those people away from ED and hoping to reduce the pressure on people like yourselves, Megan, who, you know, are dealing probably more effectively with physical issues and things like that. So part of our evaluation is to look at the, I guess, the effectiveness of these services, but we also are looking at it from a mixed methods approach. So we're looking at the data, but we're also looking at people's experiences, not just people who come and visit the services, so people who are suffering from acute crisis, but people come with them. So they're support people, the people who work there, the peer support workers, the clinical teams, and then the more management side of things as well. And not just people who work in the spaces, but also from EDs as well. So we can better understand, you know, who's coming, who's not coming, who we're not reaching from this perspective, you know, what the processes is, particularly around those referral pathways, the variability, because they're done slightly different depending on where you are, to meet the needs of those communities, and what's working, what's not working so well, so that those types of things are informing new spaces that are coming on board. So we've got one that is being co-designed and developed in Logan and also in Redlands, and there's also a service coming on in the Sunshine Coast. So we're partway through the data collection for that, and we're due to present that data in the new year. But it's really great that we're able to collect data and do research on a pilot to help inform further investment that is coming through the Better Care Together strategy.
Thanks, Zoe.
Thanks.
That's really interesting. I mean, I had a couple of questions about whether or not what you're implementing there puts a greater strain on the emergency department with these referrals.
That's a really great question because it sounds counterintuitive, doesn't it? I think that what is really important are, that's coming out of some of our initial conversations, are the relationships between the crisis support spaces and the EDs, and those clinicians that are overseeing the spaces are able to actually link into systems and to pick out people who might be appropriate for the spaces before they get. So they are actually able to do part of that triage work and clinically sign them off to be in the spaces. Because again, going back to how heterogeneous the people are, you've got people who are maybe who've self-harmed, who really need clinical seeing clinically, and then others who they need that support, that de-escalation before we can address maybe some of the other stuff. So yeah, I think there's potential there for a bit of additional work, but I think once that governance process and those relationships and trust built, then they can change some of those referral pathways and people can be presenting more independently.
So I think it's great that you're doing research on this and collecting data. Do you have an idea whether or not these crisis support spaces are actually making a difference?
Yeah, and that's a great question, and I think it depends on who you talk to, right?
Yep.
So part of what we do is make sure that we take that perspective from different lenses. So as I said, we look at the data and we're seeing that there are lots of those representations that Megan mentioned are diverting away from the ED, which is really great. We're also seeing, in the first instance, young people presenting that having a significant reduction in their distress scales overall. They're using those crisis support spaces as part of their recovery and their planning, and so they're becoming a bit more independent of their own crisis management. When you speak to people, that they say they wouldn't know what they would do without the spaces. I think that's the other thing to note, is that people attend ED because they've not got nowhere else to go. And it might be because they don't exist, particularly when you're thinking about more rural and remote areas. But even within a metro area, people don't know about maybe more community centred options. So yeah, there's a lot of work to do around improving people's mental health literacy, but also their understanding of what is available to help them when they're in need.
Yeah, fantastic. Thank you very much. We might keep moving on now. And speaking of research, we're coming to Dr. James Kesby, who's going to talk about some aspects of research mental health illness.
Thanks for having me. Excellent discussion so far. So I'm going to sort of step a little bit to the side and not really talk so much about interacting with people in the clinic, but more about what we're doing to try and understand how the brain works and maybe what we can do to prevent people coming back. My research is centred really around schizophrenia and psychosis, so a very severe mental illness that's been brought up a few times, psychosis being one of those overrepresented problems in the ED and in the criminal justice system as well. And I think, firstly, we mentioned stigma, so a few quick things. What do we know about schizophrenia? One, most people think of the psychosis, which is that very obvious behavioural change in someone when they're going through an episode, very scary for the individual and also a risk to other people around them as well and themselves. And we have some medications that can treat those symptoms in most people pretty well. But a lot of people neglect to think about the other aspects of these very complex mental illnesses. And so my focus is actually decision making and cognition. Because when we treat someone with psychosis and their psychotic symptoms are sort of controlled, they still have to go out into this complex society that we live in and navigate all these different avenues, work, friends, all these things. And when your cognition is not as accurate or as able to deal with that, you lead yourself into more problems. And some of this is that ability to maintain social networks. Some of it's to maintain a job. We all need to be happy and healthy. We need to be financially secure and have those systems in place. And that's one part where we need to sort of avoid people coming back into the clinic. The other side of it is the drugs that we do have for people with psychosis, they have a lot of side effects. And that puts a lot of burden on the person to decide what's worse for me. So my research really focuses on during those periods when we have someone who is not experiencing a psychotic episode, how can we help the brain make the decisions more accurately so they can function in their daily lives. And to do this, we run a lot of tests sort of looking at how, when your environment changes, what choices do you make and how do you change your choices? And we look at different varieties of changing, like computer games, changing tests to see how people respond. And some of the research we've done shows that people with early psychosis, that first psychotic episode, we can't predict this yet, so this is a place where ED and these services are always going to be needed. They tend to respond slightly differently to someone who doesn't have early psychosis, responding a little bit different to punishment, all right? Like, so how they respond to losses. But otherwise, most part, their cognition is relatively intact. When we look at someone who's had repeat psychotic episodes and has persistent schizophrenia, they tend to respond differently to rewards. So less likely to sort of do something that got them a good outcome again. And this is only mild, but over the course of days and months and weeks and years of living in life, that can add up to being not as successful and having more trouble maintaining these positive reinforcing things. But for me as a neuroscientist, it's what's going on in the brain that changes from that first presentation, maybe to down the line that leads to those different cognitive capacities. And how can we prevent those changes or maybe fix the problems earlier? To do that, we use animal models. So we look at mice and how they make decisions to understand how the brain networks act and respond to different environmental cues. And we start to learn, well, there's different areas of the brain that compute different parts of our world. And if some of those are problematic, maybe we need to find ways to address those particular neurobiological problems. And I think it's come up a few times that this sort of coming back to these systems is a problem. And one of the things we do know about psychosis is that every psychotic episode a person experiences tends to change the way they respond to the drugs they're currently taking. They become less effective most of the time, and also makes their cognitive function slightly worse. So anything we can do within the services we have, and also from a fundamental perspective, try and understand how we can better treat these problems, be it with support systems or other therapeutic options we have available, to maintain functioning ability to live in society, basically. Maintain your work, maintain your friends and family so that you've got those support systems, so that you've got somewhere to go back to when you have these issues. Ideally, that's the long-term outcome. We can prevent some of those re-entries and maybe in the future prevent people even getting to that first point once we know more about how the brain transitions to these severe mental illnesses. Now, I'm really interested in the discussion after this. I'm not going to speak for too long on this. I'm hoping we get some really good questions.
Thanks, James. I mean, it's really interesting about decision making. So it's the choices that we make. I know a lot of stigma with mental health is, come on, just snap out it, you know, make a better choice. But what do you think you're learning about research about how these cognitive processes are affected in serious mental health conditions like schizophrenia?
I think it's one of those things. Every mental illness, or when you're having bad mental health, there's always some level of cognition that is impaired that's associated with that. Depression, the motivation to go do something is decreased. Get out of bed and go to work. In schizophrenia, what I work on is the ability to follow goal-directed behaviour. So I've got to make a choice, which is going to be the better outcome, and make that choice over and over to keep prolonging that ability. And we talk about sort of snap out of it, addiction. So I did some research on methamphetamine abuse in the States, and obviously it's linked with psychosis because these are psychostimulants often, but everyone sort of says, well, just stop taking the drug. But the way the brain circuitry changes over time with dependence is that rather than, I want to go get this drug, it becomes something reminds you of the drug and you just do it. You're not consciously thinking. So there's not an ability to consciously say, I'm not going to do that. It's just an automatic process, like when you type in your password. And if you stop halfway through, I don't know how to do this anymore. It's just, it automatically happens. Now, it's really efficient for the brain to have those systems in place because we don't want to think about every choice we make. But when those systems sort of take over, it can be very hard to untrain that. So I think appreciating these sort of cognitive problems and finding better ways to understand what's wrong, how we can sort of reshape those associations can help with a lot of these different disorders.
That's really interesting. And do you think using these animal models is going to help us understand what to do better in terms of frontline mental health services, or is the animal models more to understand more about the mechanisms about why people get severe mental health disorders?
I think it can go both ways, but it takes longer to get to one than the other. The real benefit is sort of, I think of it like our brain is super complex. No one can understand every facet of it, right? But it's a black box. We can't get in there and tinker, right? It's kind of like someone rocks up with a car and says something's wrong with it, and you don't know what the engine is. How long would it take you to figure out it's an internal combustion engine or a battery-powered car, right? It would take you forever. Whereas with the tools we have with animal models, we can actually look more directly at what's going on in the brain. And you know, a lot of animals need this, everything needs the same drive. You need to chase a reward, you need to get food, you need to survive. So these motivational patterns and these cognitive principles that we all rely on are sort of the same across species. So they do have that ability. But then I think the tricky bit is, well, we're humans, we're different, we live in a different society, so you have to be able to look at both sides of it. So you've got to test people to understand how humans make decisions, and how is that different or similar to other animals, and where can we say that these things are related and learn from them.
I guess it's true, there's a lot we need to learn about the brain as well as mental health. So thanks to all of our panel. I think there's been a very interesting discussion. I thought I'd open out and just go to there's a couple of questions we could start, and I thought I'd just start with a really sort of polarising one. With a limited amount of money, maybe just starting with Ed and then working across, where do you think we should target our investment in order to fix mental health in the community?
Wow, you would have to start with me, wouldn't you, Tom? You know, that is really, really tricky. And I mean, I think really community services are crucial because, you know, keeping people in their environment is good for their mental health. Having said that, one of the things that we're really struggling with at the moment, and I think there would be nobody that would think differently that works in the mental health system, whether it's private or public, and I accept that this is a very kind of hospital-based thinking, but we do have a bed problem. And we really are experiencing, you know, long delays for people getting into beds at the moment. And so I think, you know, I really think that, you know, having enough beds for our population is really critical. So that's an area I think that's really important. But the thing is that there has to be a mix of services. So what Zoe's been talking about is going to make our system much more efficient. The work that we do with police and first responders in helping divert people away from emergency departments when they don't need to be there, because of course some of them absolutely need to be there, but a significant proportion, they're not actually going to get the best result. They're going to get a better outcome going to a peer-led service or going to an NGO service. So, I'm going to do something that I rarely do and hedge my bets and say we need to invest in a number of different areas in the mental health system, because my belief is that it has been subject to sort of chronic underfunding across the board.
Agreed. Megan, did you have a...
Yeah, I don't have a different opinion, but I guess just to add to that, I think beds, yes, but more funding towards people. Like, we definitely need more mental health clinicians. Like, all of these services, they're just spaces without trained people that can provide help on the phone lines, in community services, in hospital. Like, I think it's a large gap. People are always waiting to be seen by people.
Yep.
And it's got to be a one-on-one sort of contact.
Zoe, do you
Gosh,
disagree or agree?
I don't disagree at all, because I think it's a whole system approach that we need.
Yep.
And if everybody within that system pooled that little bit of money that you talk about,
because I guess that's a problem. It's a little pot of money with so many different services that we could fund. How are we going to break that problem?
Absolutely. Well, we need to know where to start, really. So to have better data and linkage of data would really go a long way. I mean, Megan talked about, not being able to do her job as well because the ED and the SIMA data systems don't talk to each other, and having to rope somebody in from the mental health side of things, really puts a lag on stuff. So I think definitely, improve the data collection, quality, validity and reliability of it, so that we know then who are the people who most at need. So that we can use evidence-based practice to then pilot those adaptations that need to happen in a different context. So, I think there is a drive to, just do something because there's a problem. But if we're take our time a little bit more and a bit more targeted and more purposeful about piloting stuff, then you're going to get a better return on investment and waste less money effectively.
And James, I guess this is the difficult thing, because obviously the areas you're researching aren't going to help someone find a bed tomorrow, but we do need to think about the bigger picture and the longer term. How do we deal with the broader research idea about understanding mental health?
I agree with hedging the bets and spreading it around, and I think long-term thinking is important. I suppose more clinicians, perfect. We need more people on the ground that know what they're talking about. What tools do they have available? It's what we have, right? So for schizophrenia and psychosis, there's a couple now going through phase 3, but there hasn't been a new drug developed in my lifetime. That's a long time, right? So, and the drugs that we do have are kind of stumbled upon by chance. Research, chance though, and that's, I think that's the blue sky approach that we have to have as researchers at my level, the fundamental things. It's those little things you learn and tinker at, and eventually some of that comes together and you go, actually, the esketamine for major depression, for example, was stumbled upon as an idea based on schizophrenia research, but now it's treating major depression, which was largely untreatable. So it's these sort of breakthroughs that then give the clinicians that we have better tools to help work with and help these people who are suffering from these disorders. Some of them we don't have any treatments for, and services and everything can help, but that person is in a problem situation that we need to find better ways to deal with that as well. So hedge, but some short term and some long term.
But ultimately we need to prevent a lot of these conditions occurring in the first place. So prevention, and early intervention is a key. We've got some fantastic data now coming out of the child maltreatment study. So investing more in families and the prevention at that early age it is also really important. But you said only a small amount of money. So.
Well, it's the problem that we have. There's not enough money to go around. But I think prevention is really important. But how you identify that in a community as someone who's likely to need these services seems to be very difficult. We don't have anyone on the panel with a lived experience, but I was just wondering, maybe Ed, we could start thinking about from a patient-centred approach. How do you think someone who has a mental health issue could be more involved in research or directing the types of services outcomes that would benefit them?
Well, the first thing I'll say is that that's a key to actually successfully developing services and to doing good research. So, that's a must. That's something that we must do now. We must involve people in the planning. How are people involved? Well, I think actually, I'll talk for the mental health system here, but you know, the mental health system has got very good at engaging consumer groups, consumer consultants, respecting the knowledge and lived experience through things like paying people for their time, actually having professional positions, and I think that's that's gone a long way to engaging individuals into into planning and into research, and I think that's critical, because it takes a lot of time, and people have to be respected, and I think the other thing is carers. I think carers have a really extensive body of knowledge, and have often seen systems in ways that we don't see them. Mm-hmm. And engaging carers in service development and in research, I think will really add a third dimension to those systems as well.
I think it's a really interesting point you make about not seeing the whole system. We all work in our areas. We see our fractioned portions of it. It's not the same as having experienced the whole journey from community pre-hospital all the way through to an admission, and there's a lot of insight that could be gathered in terms of what could be done better.
Is there much research going on in emergency departments in terms of people, what happens to them, where they go? Or are you too busy to even think about that at the moment?
There's a lot of research that goes on in emergency departments. I'm not familiar with anything that's specifically focusing on the journey of our mental health discharge patients. We certainly have done, there's been a lot of work that's gone on with our portion of sort of frequent presenter patients to try and engage them in their own management plans, and come up with the multidisciplinary teams that have been involved in how to optimise their care in the future, and it's been very effective. But again, this is one group of patients. Yeah.
We include people with lived experience across the whole range of our research. So we have the people who have specific lived experience to the different types of services that we're evaluating, be part of our steering groups, and we invest in them as co-researchers throughout that process and help to upskill them. Something that we've really, we can really value that input in terms of adapting what we know to be valid and reliable measures and tests from a research point of view. But, we're less knowledgeable about how do we access people who have a lived experience to take part in our research. So, having that insight has really helped to adapt how we do and what we do. And we have had fantastic responses to several of our evaluations in terms of people wanting to come have a chat with us. We make sure that we remunerate them or accordingly. But as researchers, then you have a responsibility to genuinely listen and respond to people when you include them within what you're doing, whether it be in terms of service design or the research that you're doing, because nobody likes a pseudo consultation, right? And so part of that is also then closing the loop as well and informing people about how did you make a difference in what we're doing, and how did your experience, coming from somewhere probably from a negative perspective, actually produce a positive. And we've had some overwhelming stories of some of our participants who have said how empowering it's been. So I think it's, can be quite challenging, but it's super rewarding, because effectively you are building a better product at the end of it.
Yeah, well, that's great to hear. I mean, James, in terms of basic research, do you find there's much engagement with people with lived experience or parents of children with?
I think it's definitely increasing for multiple reasons. So I suppose for us it's recruiting people who want to be interested in participating in the research. So behind the sort of black curtain of the research, they can't be involved if they're a participant, but we are hoping to sort of get more, so I suppose, steering committees, because as a researcher you want to get as much information as you can. But having someone sit there for 4 hours doing questionnaires and stuff is really boring and a burden. So you've got to pick which is the most important. And I think some of those things could be really helpful to have people who have lived experience and say, oh, this bit was really challenging to get through. Okay, so maybe we can find a short version of that and use our time more wisely to get better data and those sort of things. So I think that's really important. Also, the wording and how some of these surveys are presented that we use to get that data can be improved upon. And then I think, for me, I talk to a lot of people with lived experience in the CCUs we go to recruit, tell them about what sort of research we're doing, why we're interested in it, and just the general feedback you get is really useful because, oh, I have issues with this part of that, that's really interesting. Okay, so then we think, well, maybe we need to look at that a bit more carefully. We can change our research for the next project. So I think that level of involvement in our type of work is really important. And just the acknowledgement amongst the community that research isn't scary. You come in, you can participate in research and do something good, and you get remunerated, you get something out of it as well, but it also is contributing to a bigger body of knowledge and hopefully will help people beyond yourself in the future.
That's fantastic. So on this Zoom webinar, there is a chat function. So if you want to put your questions into the chat function, I can find one question here. So was a person identified, lived experience of mental illness or suicide invited onto the panel for today? I don't know the answer to that. I don't think so. And do we have identified lived experience roles here at UQ? I don't think I can answer that question.
I thought I'd talk just on a sort of sideways note on that. One of the things that we did in the Partners in Prevention research, which is the research I talked about earlier, was we engaged a lived experience organisation to be a partner in the research. So one of the partners in Prevention was an organisation called Roses in the Ocean, and that was really successful in terms of being able to engage people with lived experience. So we had members on our steering group, we had members on the working groups. One of the areas that, or one of the reports that we were able to produce occurred because there was a forum run by Roses in the Ocean, and now our researchers were able to attend that forum and then able to ask people some fairly simple questions like, how would you like to be responded to if you were experiencing a mental health crisis? How would you design a service system to meet your needs in a mental health crisis situation? And I can tell you that that was really rich and important data, and has really filtered into the way we think about our mental health system design and about the results from our research and how we translate those research findings. So that was really useful. And another really interesting way we engage people in with lived experience was when we did a study, going back a little bit now, but called Inside Out, which was a study on the mental health needs of Aboriginal and Torres Strait Islander people in custody. Okay, so you would think this is going to be really difficult to engage people, but in fact, we had a community of people with lived experience who wanted to be in that project, and we found ways of being able to reimburse them through the buy-up systems in custody, and that group was really engaged, provided huge amounts of information, and I'd have to say was again incredibly helpful to our research as a whole. So my experience has generally been that if you can identify lived experience organisations and engage them in the research, they can often give you really good advice about how to engage people.
That's an excellent point, Ed. We've just got another question here, and it really, Megan, I think, would be able to answer this one about increased mental health presentations to emergency departments and the pressure on resources available. Is this an argument for purpose-built mental health hospitals?
Hedging a little bit. Yes and no. I think there's definitely benefits in any sort of subspecialty hospital in that people that can self-identify can go there, can receive subspecialty care that they require. However, the risk of sort of fractioning, you know, there's not an endless amount of money unless this is funded separately. You're taking funding away from somewhere else. A large number of our we see quite a lot of mental health patients, particularly after COVID, that their triage note looks nothing like any mental health symptoms until you go and chat to them, and you realise that actually their physical complaint that they're presenting with is less of an issue, and it's more of a mental health problem that they're presenting with. So I think there definitely could be a place for it if you had increased funding overall to have these subspecialty centres. But I guess at the Royal Brisbane we already sort of had that inbuilt in with the psychiatric emergency centre, and it's still, you've got an overcapacity issue, and you need to have all of the resources in place with security and with other staff available for when things might escalate. Or
do you think that's a risk of going back to an institutionalisation type policy, and maybe these crisis support spaces and bring it out to the community? Maybe that's where we need to do more investment. I mean,
I do feel like this seems like more of a way of the future. Patients are increasingly more and more educated and wanting to be more involved in their own healthcare and own decision making. Gone are the days of this is the treatment, off you go. Patients want to know why and want to know what all the options are in their care, and as they should and as they have every right to. So I don't think it's a bad idea, but I think satellite hospitals everywhere just ends up fragmenting care, and this is still our core business in emergency. But yes, perhaps I think for those lower acuity patients, for those there are better places.
Is there a plan to move into more crisis support spaces more broadly throughout Queensland?
There are, and I think that there will be another call through Queensland Health for the different HHS to put proposals together. There's also other community-based crisis support spaces or safe haven cafes, for example, that are being opened up through the PHNs and so on. I'd like to see much better linkage between them, and I think that we need to, and particularly as part of the research that we're doing, understanding what does that need to look like, and why people opting to represent at the crisis support spaces that are hospital situated versus going to the community-based ones. And again, it might well be because of their awareness or accessibility. That's another issue as well. I just wanted to touch on the question around the mental health.
Please do.
Sorry, the lived experience researchers. Within UQ, I'm not aware of a dedicated group who identify as lived experience researchers, but there are many people who are doing mental health research who do have lived experience, and there is a distinction, and there are some fantastic trailblazing lived experience researchers such as Louise Byrne and Michelle Banfield, who are doing fantastic work in this space, particularly around growing the peer workforce and the lived experience workforce. But we also have things like the Alive network, which is a national thing, but also there is a Queensland-based network as well. So there are lots of people, like I say, who identify formally and use that lens as part of their research. But there are also researchers who have lived experience, who, with a little L, I suppose, who use that to inform what they do as well.
Great, thanks, Zoe. Well, I think we've about run out of time, so I just want to thank our panel, Ed, Megan, Zoe and James. I think we've had a really good discussion. We sort of covered the importance of prevention, treatment, recovery and research. This webinar has been recorded, so you can always go back and have a look at it. Please feel free to do so. If you're interested in supporting QBI, we have a mailing list that you can join on, and there's some philanthropy. So at the moment, the donations go to the Brain Research Endowment Fund are being matched by UQ's Giving Day until the 18th of October. And so we can share a link with you after the webinar if you're interested in donating. So we look forward to keeping up to date with our research, and thank you for taking part in this webinar. And thanks again to the panel.
Thank you.